everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. In this video, we will discuss all the bone and soft tissue tumors. So, bone and soft tissue tumors pathology will be dealt in this video. It will be slightly a little longer volume or large in size. So, please bear it. This is a very important topic which most of them will leave, but it is very important diagnostic point of view. Before going into the bone and soft tissue pathology, I want to discuss a few important points related to the bone. As all of us know, we have this is all marrow. You can see all the vacuolated cells, they are fat cells. These are all marrow cells, and these are bony trabeculae. Okay, clear? Coming to the when we see in under the microscope, you can appreciate cells, one in the corner which are mononuclear. Okay, these are osteoblasts, and at places you can appreciate multinucleated cells. These are osteoclasts, and this remaining is bone and cartilage. Okay, and in this picture you can appreciate again these mononuclear cells, they are osteoblasts. Okay, and these multinucleated cells, they are osteoclasts, osteoblasts and osteoclasts. This is what are these cells? Can anyone guess? Osteoclast, osteoblasts, osteocytes, none of the above. They are osteocytes. Okay. So with this brief knowledge, we will start our video on bone and soft tissue pathology. Among the bones, there are tumors. These bone tumors can be primary and secondary. And among the primary bone tumors, there are again benign and malignant tumors. Benign tumors are more common in younger people, and malignant tumors, bone tumors, are common in elder people. The most common bone tumor will be the metastatic tumor or metastasis or secondary bone tumors. The most common metastatic bone tumor will be in males it is prostate cancer, and in females it is breast cancer. Coming to osteoblastic secondaries, prostate or carcinoid. Osteoclastic secondaries will be breast or lung cancer. And most of them are multifocal, all the metastases. But in RCC and thyroid cancers, they are unifocal. The mechanism by which metastasis occurs is called as pulsatile mechanism in RCC and thyroid cancers. Bone forming tumors will be around 26%. Out of them, they can be benign tumors and malignant tumors. Osteoid osteoma and osteoblastoma are benign bone forming tumors, and osteosarcoma is a malignant bone forming tumor. Both osteoid osteoma and osteosarcoma will come from metaphysis of distal femur or long bones, and the age group for all bone forming tumors will be most of the time it is 10 to 20 years. There will be cortical interlacing microtrabeculae of woven bone in osteoid osteoma. Posterior elements of vertebrae are involved, and histology is similar to osteoid osteoma. But the main difference between osteoid osteoma and osteoblastoma will be Osteoid osteoma tumors are less than 2 centimeters or 2.5 centimeters in size, whereas osteoblastoma will be more than 2 or 2.5 centimeters. This is the difference between osteoid osteoma and osteoblastoma. Remaining everything is almost all the same. Coming to osteosarcoma, it extends from medulla and it will to lift the periosteum. And the malignant cells will produce the oven bone. This is your osteosarcoma. We will discuss them in detail one by one. As in the previous slide, I have told bone forming tumors will be osteoid osteoma, osteoblastoma, and osteosarcoma. Osteoid osteoma and osteoblastoma are benign tumors, 10 to 20 years age. Histologically, both are looking similar. Only the size will be different and the location will be different. It is around less than 2 centimeters or 2.5 centimeters, seen mostly in diaphysis of the tibia and few metaphysis also. In osteoblastoma, it will be involving the spine and the size will be more than 2.5 centimeters. When you observe the radiology picture, you can appreciate a round structure here. Okay, around this is all bony trabeculae. This is nidus or nidus, whatever you say. Okay, when we see it in microscopy, this is the nidus. Okay, and surrounding it, everything is bony trabeculae. Okay, these are all bony trabeculae and this is nidus. Okay, so histologically, both osteoid osteoma and osteoblastoma will look similar, same. Nidus and bony trabeculae are the features. Coming to osteosarcoma, it is the second most common primary malignant tumor of the long bones, and it will be presenting as painful, bulky, gritty mass in metaphysis region most commonly, and it involves lower end of the femur and upper end of the tibia. There will be bimodal involvement, that is primary osteosarcoma are seen in age group of 10 to 20 years and secondary osteosarcomas are seen in people more than 40 years age. And male to female, males are having osteosarcoma risk more when compared to females. The characteristic radiological features of this osteosarcoma will be Codman's triangle and sunburst appearance. Okay. On microscopy, you will observe a lace-like pattern. All the atypical tumor cells which are pleomorphic will form the mineralized bone and they will be in thin, lacy, eosinophilic, glassy osteoid appearance. This is also called as lace-like pattern. These tumors are generally radioresistant and the most common subtype of osteosarcoma will be among the low grade and high grade it is high grade, among the primary and secondary it is primary, and among the intramedullary is the most common subtype and osteoblastic type is the most common type of osteosarcoma. Coming to the see here this is Codman's triangle. Okay, Codman's triangle. If you see this is bulky mass and this arrow is indicating the Codman's triangle. Okay, this is the gross picture. You can see all the tumor tissue, Codman's triangle. This is giving the appearance of sunburst. See, like the sun has been bursted. This is called as sunburst appearance on radiology. And coming to the microscopy, if you see, these are bony trabeculae, pink ones, and this is tumor tissue. If we zoom and see, You can see all the tumor cells are of different shape. They are atypical, pleomorphic. And if you see, they are present and around them there is thin, lacy, eosinophilic, glassy osteoids. So the tumor cells are present within this osteoid. This is one more picture showing more zoom, high magnification. You can see the tumor cells, and this is osteoid. Till now, we have discussed the bone-forming tumors, osteoid osteoma, osteoblastoma, and osteosarcoma. 10 to 20 years age group. Osteoid osteoma and osteoblastoma are benign, and osteosarcoma is malignant. Sunburst appearance and Codman's triangles are characteristic lace-like pattern on microscopy because of the osteoids. And atypical tumor cells are seen in osteosarcoma. And primary osteosarcomas are most common. High-grade osteosarcomas are most common. Now, with this knowledge, we will discuss cartilage-forming tumors. Bone-forming tumors will be 22 to 26%, whereas cartilage-forming tumors will be around 30%. Again, these cartilage-forming tumors are also both benign and malignant. Benign includes osteochondromas, chondromas, chondroblastomas, chondromyxoid fibromas, and malignant includes chondrosarcomas, conventional type. Osteochondromas are seen most commonly in metaphysis of long bones. Chondromas are seen small bones of hands and feet. Chondroblastomas are seen in epiphysis of long bones. Chondromyxoid fibroma is seen in tibia and pelvis, and chondrosarcomas are seen in pelvis and shoulder. And if you see the age groups, chondroblastomas and osteochondromas will be 10 to 20 years age group. Chondromyxoid fibroma will be 20 to 30. Chondromas will be 30 to 50 years, and chondrosarcomas will be 40 to 60 years. And bony excrescence with cartilaginous cap is seen in osteochondromas. Circumscribed hyalinized cartilage or hyaline cartilage nodules in the medulla is seen in chondromas. Circumscribed pericellular calcification is seen in chondroblastomas. And collagenous to myxoid matrix with stellate cells are characteristic of chondromyxoid fibromas. And the malignant cartilage forming tumor, that is chondrosarcoma, which is seen in pelvis and shoulder, will extend from medulla through cortex into the soft tissues chondrocytes with increased cellularity and atypia. Among the cartilage forming tumors, enchondroma stands the first place. It is associated with Maffucci syndrome and Ollier syndrome. In Maffucci syndromes, there will be enchondromas, gliomas, hemangiomas, and ovarian tumors. And in Ollier syndrome, it is only multiple enchondromas will be seen. And for enchondromas, they include the hands and feet. This is a picture from Pathology Robbins. And if you see here, there is a enchondroma present. It is enchondroma of the proximal phalanx. You can appreciate the radiolucent nodule of cartilage with central calcification, but it is not penetrating the cortex. Okay, this is the important feature. In both the microscopy pictures, you can see the enchondromas with reactive bone, pink in color, and this is all cartilage. Now in this slide, we will discuss the osteochondroma or exostosis, which is also a cartilage forming tumor, and it is most commonly seen in the metaphyseal region, upper end of tibia and femur. The genes that are involved in exostosis or osteochondroma are EXT1 and EXT2 genes. Most of the times, these osteochondroma is asymptomatic, present in adolescents, and compared to females, males are presenting with osteochondroma more when compared to females. Actually, these osteochondromas look like, if you see the picture gross, it is like a mushroom shape. Osteochondromas are mushroom shaped and they will be of size from 1 to 20 centimeters. If you observe clearly the gross picture, the outer layer of the osteochondroma is composed of benign hyaline cartilage of variable thickness, and the newly formed bone is in the inner portion of this head and stalk, with the stalk cortex merging with the cortex of the host bone. So this is a picture you can appreciate. This is the long bone. Okay. Here you can appreciate there is exostosis. This is osteochondroma. This can be shown in the picture. Suppose this is your normal long bone. When there is exostosis, there will be like outgrowth, right? This is growing and forming finally like this. If you appreciate this, we after grossing, there will be outer cartilage and inner portion of this will be with your newly formed bone. So this picture is showing, see how glistening outer layer of this osteochondroma. Okay, this is made up of hyaline cartilage, and you see the tumor cells. This is the inner portion, newly formed bone. Okay, this newly formed bone forming the inner portion, the cortex merges with the cortex of the host bone. Again, when we do this on microscopy, you can appreciate this white glistening area. You can compare, right? This is your benign hyaline cartilage, and inner you can appreciate all the newly formed bone. The next cartilage forming tumor will be chondroblastoma. This is having three important features which you have to remember at any cost. First, you can appreciate these giant cells, right? So this is the first feature, giant cells. Okay, chondroblastoma, giant cells. Okay, then if you see the individual cells here, okay, in this cell, okay, in this cell, here also this cell, if you see, you can appreciate the grooving. So grooving in the nucleus is the second feature of chondroblastoma. And when you observe this picture, you can appreciate blue colored thing around each cell. So this is blue is H&D blue means calcium. Okay. So calcification around each and every cell. So this is all blue color is calcification. This looks like chicken wire. Okay. So this is called as chicken wire calcification. So for a chondroblastoma, three important features. One is you have to see the giant cells. Second, there will be nuclear grooving or grooves and chicken wire calcification. You can appreciate in this picture also multinucleated giant cells in the chicken wire calcification, and in the few cells there is nuclear grooving. So this is a cartilage forming tumor, chondrosarcoma. This is a malignant tumor of the chondroblasts. Age group involved will be 40 to 60 years, and males are frequently involved when compared to females for this tumor. And the origin for this chondrosarcoma is seen in metaphysis. The pelvic bones are mostly involved when compared to shoulder and ribs. And it presents as painful, gradually enlarging mass. The mutations involved will be IDH1 or 2, and EXT mutations are also seen in few cases. The spread is by local spread or by blood spread. If there is metastasis, the metastasis will be more common to the lungs when compared to brain and kidney. And on radiology, you can appreciate this spotty calcification sometimes, popcorn type of calcification and ring-like ossifications. Okay, so this is characteristic of chondrosarcoma, popcorn calcification or ring-like ossification or spotty ossification or spotty calcification. So when we see this is a bulky mass looking like mucoid material, right? So gross also it appears like that, bulky mass, mucoid in appearance. And if you see the cells, they are malignant cartilage cells, okay, permeating the marrow. You can see one, two, okay, one, two, three, okay, one, two, three. So they are permeating the marrow. Malignant cartilage cells are permeating the marrow. This is a characteristic feature of chondrosarcoma. Permeation is present in chondrosarcoma. Simply remember like that. Okay. And the most common will be out of the grade 1, grade 2, grade 3 type of chondrosarcomas. Grade 1 is the most common type. Conventional subtype or classical subtype or intramedullary subtype of chondrosarcomas are the most common type of chondrosarcomas. As they are non-responsive to the chemotherapy, surgery is the mainstay of treatment. You remember all these cells. These are malignant tumor cells permeating into the marrow. Till now, we have discussed bone forming tumors and cartilage forming tumors. Now we will discuss bone tumors, primary bone tumors, which are of unknown origin. They are around 15%. Again, these are also of benign and malignant type. Among the benign tumors, they are giant cell tumors and aneurysmal bone cyst will come. And malignant tumor will be Ewing sarcomas and adamantinoma. Giant cell tumors are seen in epiphysis of long bone in the age group of 20 to 40 years. And these giant cell tumors, the mononuclear cells that are the malignant cells, will destroy the medulla and cortex, and there will be sheets of osteoclasts present. In the aneurysmal bone cyst, which is seen in 10 to 20 years age group, in the proximal tibia or distal femur or vertebra, there will be hemorrhagic spaces separated by cellular fibrous septae, which is a characteristic feature of aneurysmal bone cyst. Coming to malignant tumor, Ewing sarcoma raises in diaphysis of long bones, 10 to 20 years age group, 1122 translocation, EWSFLT1 gene involvement is there. It is a small blue round cell tumor, sorry, and there are sheets of primitive small round cells on microscopic. Coming to adamantinoma, it is present in tibia, 30 to 40 years age group. There will be cortical fibrous bone matrix with epithelial islands. These are the features of giant cell tumor, aneurysmal bone cyst, and Ewing sarcoma and adamantinoma. Here, we are going to discuss the aneurysmal bone cyst. If you see this picture, what are all these? What is this? This is blood vessel. Okay. Around the blood vessel, you are appreciating the multinucleated giant cells. See, these are all multinucleated giant cells. Okay. So around the blood vessel, if you appreciate multinucleated giant cells, then it is aneurysmal bone cyst. This is the characteristic feature of aneurysmal bone cyst, and aneurysmal bone cyst is seen in proximal tibia, distal femur, vertebral bodies. The hemorrhagic spaces are separated by cellular fibrous septae, and there will be giant cells seen around this blood vessels or hemorrhagic spaces, and this is called as aneurysmal bone cyst, which is a benign tumor. Bone tumors, primary bone tumors of unknown origin, among them benign tumors and malignant tumors. In the benign tumors, we have seen aneurysmal bone cyst. One more bone tumor is there, that is of unknown origin, osteoclastoma or giant cell tumors. They are benign tumors, and if you see, the tumor is giving the appearance of a club. So it is a club-shaped tumor. The origin is from primitive stromal cells. The age group involved is 20 to 40 years. Among all the tumors, osteoclastomas are the only tumors that are most commonly involved in females when compared to males. Remaining everything is seen in males, but females are more prone for osteoclastoma or giant cell tumor. And it involves the epiphysis region, upper end of tibia and lower end of femur. Among the upper end of tibia and lower end of femur is mostly involved in giant cell tumors when compared to upper end of tibia. This is one more interesting point about the giant cell tumors. There will be, as a tumor is present, there will be pain, there will be frequency of fractures. So pathological fractures are common in these giant cell tumors, and the spread is by local spread or by blood spread. On radiology, we can appreciate the tumor. Okay, this is all tumor. See this tumor. Okay, so on radiology, it will give soap bubble appearance, and on gross examination, it will give honeycomb appearance. And on microscopy, you can appreciate the multinucleated giant cells and the mononuclear stromal cells. Osteoclastic giant cells are seen in giant cell tumor, but they are of tumor, they are not tumor cells. The tumor cells are these mononuclear stromal cells. And this osteoclastomy, even though it is a benign tumor, there is a high chance of malignant transformation in giant cell tumors. This is one more interesting finding. So, osteoclastomas or giant cell tumors consist of two types of cells, mononuclear stromal cells, which are malignant cells, and multinucleated giant cells. Mononuclear tumor cells are the tumor cells, and there is a high chance of malignant transformation. On radiology, soap bubble appearance, and on gross examination, honeycomb appearance. Females are more involved, 20 to 40 years age group. Lower end of femur is mostly involved, and pathological fractures are more common in this tumor. Malignant bone tumor of unknown origin. Primitive neuroendocrine cells are seen in Ewing sarcoma. So this is comes under a small round cell tumor or benign tumor, and most commonly this Ewing sarcoma is seen in the diaphysis region, tibia, femur and pelvis. There will be a translocation of 11, 22. EWS is present on 22 and FLT1 is present on 11. So EWS FLT1 changes will result in Ewing sarcoma. Remember E for 11 and E for Ewing. Okay. And sarcoma, yes, if you reverse it, it will appear like 2. So double it, 22. Translocation 11, 22. Okay. Age group is 10 to 15 years. You can remember like 11 years also you can remember for easy remembrance. 11 location, 11 translocation. 11 years, 11 translocation. Males are most involved when compared to females in this Ewing sarcoma. Painful mass It will mimic like osteomyelitis. You have to remember this point. Ewing sarcoma will mimic like osteomyelitis. And on radiology, on radiology, the appearance is onion skin appearance because of the periosteal reaction. On gross, you can observe it has a gray-white mass. When you observe under the microscope, you will appreciate all blue round cells, small blue round cells with homer-right pseudorosettes. These are all tumor cells. At the center, there is neuroendocrine material. So, pink center surrounded by cells. So, pseudorosettes, homer-right pseudorosettes. So, small blue round cells and homer-right pseudorosettes are characteristic of Ewing sarcoma. And the immunohistochemistry marker will be CD99 or MIC2. The spread will be by local or blood spread, and bone to bone metastasis is more common in Ewing sarcoma. This is the special feature of Ewing sarcoma. 11 years, 11 translocation, EWSFLT1 gene involved onion skin appearance because of periosteal reaction, small blue round cells, homer-right pseudorosettes, MIC2 or CD99 marker, and bone to bone metastasis. If you see around the cells, there is white space, right, at places. Okay, here also, here also, here also. Okay, this is in HND. This is all glycogen. It is not stained. So when you do the special stain, what is the special stain? Periodic acid skiff, right? Periodic acid skiff diastase sensitive. Then this glycogen is stained with pink color. Okay, PAS DS. Remember, periodic acid skiff diastase sensitive Ewing tumor. For your easy revision and repetition, I have made this chart for all of you with all the important bone forming tumors, cartilage forming tumors, and tumors of unknown origin. They are osteoid osteomas, osteochondroma, osteosarcoma, chondrosarcoma, giant cell tumor, and Ewing's. Osteoid osteoma and osteoblastoma, they are benign tumors and they look similar. Okay. And the age of involvement will be 10 to 13 years. Diaphyseal region, tibia is involved. There will be nocturnal pain, characteristic of osteoid osteoma. On radiology, we'll observe the nidus with sclerotic bone. And on gross, it is a well circumscribed tumor. Microscopy shows woven bone lined by osteoblasts. Coming to osteochondroma, it is a adolescent tumor. Males are more involved. Metaphysis region, upper end of tibia and femur. Most of the time, it is present as asymptomatic. There will be cap made up of hyaline cartilage and looks like mushroom shaped. Outer cap and inner lamellar bone of is present. This is a characteristic feature of osteochondroma. Osteosarcoma, it is a primary malignant tumor of bone and bimodal population is involved. That is primary 10 to 20 years age group and secondary more than 40 years age group. Metaphyseal region, upper end of the tibia and lower end of femur is a painful mass, local or blood spread. Characteristic radiological findings will be sunburst appearance, Codman's triangle. It is a bulky mass with osteogenesis and sarcoma cells. Coming to chondrosarcoma, it is the malignant tumor of chondroblasts seen in 40 to 60 years age group. Mostly metaphysis, medullary cavity is involved. Pelvis is more involved when compared to shoulder and ribs. It is a painful mass spread by local or blood. And on radiology, there will be popcorn calcification or ring-like ossification, spotty calcification. Grossly, it will appear bulky mass which is mucoid. And microscopically, you can appreciate malignant cartilage cells and it is graded into grade 1, grade 2 and grade 3. Grade 1 is the most common one. Coming to giant cell tumors, they are of unknown origin, also called as osteoclastoma. Primitive stromal cells are expecting the cause for giant cell tumors. 20 to 40 years age group. This is the only tumor where females are having the more preponderance when compared to males, and epiphysis is involved, upper end of the tibia and lower end of the femur. Lower end of the femur is mostly involved when compared to upper end of the tibia, and there will be pain, and pathological fractures are more common in this giant cell tumor. Spread is by local or blood. Soap bubble appearance on radiology and honeycomb appearance on gross examination. You can appreciate multinucleated giant cells, but the mononuclear stromal cells are the tumor cells. So two types of cells, mononuclear stromal cells and multinucleated giant cells. Coming to the last, Ewing sarcoma. It is a primitive neuroendocrine tumor seen in 11 years or 10 to 15 years age group. In the diaphysis region, tibia, femur and pelvis is a painful mass spread by local or bone. On radiology, onion skin appearance. On gross, it will look like gray white mass with small blue round cells and homocyte rosettes on microscopy. These are the radiographic pictures and microscopy pictures of all these 6 tumors. Till now we have discussed all the important tumors of the bone pathology. Only one is remaining, that is adamantinoma. In the history, if they have given tibia or the tibia is involved and the picture, microscopic picture is like this, or if the jaw is involved and microscopic picture is this, or suprasellar region is involved and microscopic picture is like this. In all these cases, you have to remember two important points. One is you are appreciating palisading, and the second one is stellate reticulum. This is palisading. You can appreciate, right? Clear? This is all palisading again. So this is also palisading. Entire palisading of cells is there. Okay. And there is stellate reticulum. It is appears like loose stellate reticulum. So palisading and stellate reticulum is the microscopic finding, and these findings are common in adamantinoma, amyloblastoma and craniopharyngioma. All these 3 tumors, adamantinoma, amyloblastoma, craniopharyngioma, will look same on microscopy. Only the site or origin changes. If it is given tibia, then it is called as adamantinoma. If it is jaw, it is called as amyloblastoma. And if it is suprasellar mass, then it is called as craniopharyngioma. In this slide, we will discuss fibrous dysplasia, which is associated with McCune-Albright syndrome. If you see the microscopy, you can appreciate all these. Okay, these are all trabecular, right? These are all trabecular. Everything are having a characteristic feature, right? What is that? Yes, it is like a fish hook. Okay, fish hook, or they are like curvilinear pattern. Curvilinear or fish hook or Chinese letter pattern is characteristic of fibrous dysplasia. Okay, and if you see, there will not be any. Normally osteoblasts will be at the corner, right? But here you will not be able to appreciate the osteoblasts. So osteoblastic rimming is not seen in fibrous dysplasia. This is an important finding. Chinese letter or fish hook or curvilinear pattern and no osteoblastic rimming, then your answer will be fibrous dysplasia. It is associated with McCune-Albright syndrome. One more tumor is condition is there called as non-ossifying fibroma, which is also showing Chinese ladder pattern or fish hook pattern or curvilinear pattern. But if you appreciate, there is a slight difference. You can observe the osteoblasts in the periphery, they are rimming. So osteoblastic rimming is seen in non-ossifying fibroma. Osteoblastic rimming is absent in fibrous dysplasia. I have kept this slide only to tell this point. If there is osteoblastic rimming, it is non-ossifying fibroma. If there is no osteoblastic rimming, it is fibrous dysplasia. Coming to bone tumors of notochordal origin, that is chordoma. It is a malignant tumor present in the sacral region of age group 30 to 60 years. It will destroy the medulla and cortex. You can appreciate the myxoid matrix and foamy cells. So, on microscopy, this is a chordoma demonstrating the cells with vesicular chromatin. And if you appreciate the cytoplasm, it is looking bubbly. This type of cytoplasm is called as bubbly cytoplasm. And these cells are called as physalliferous cells. So, physalliferous cells are cells with vesicular chromatin and bubbly to vacuolated cytoplasm. And physalliferous cells are characteristically seen in chordoma. Primary bone tumors of hematopoietic origin carries 20% and they show malignant behavior, and these tumor types can be myelomas or lymphomas. The common locations will be vertebrae and pelvis. Age group will be 50 to 60 years and morphology will show malignant plasma cells or lymphocytes replacing the marrow space. This is a picture showing the metastatic tumor. These are all metastasis. If you appreciate this, these are all red blood cells, right? All red blood cells, right? Okay. And you see all cells with nuclei, okay? And the cytoplasm is clear cell cytoplasm. So the primary tumor will be renal cell carcinoma, mets to bone marrow, okay? So this is a picture showing everything red, like mosaic pattern. This mosaic pattern with cement lines and cracks is characteristic of Paget's disease of bone. So Paget's disease of bone, remember 3 points: mosaic pattern, cement lines, and cracking. This is entirely different from the Paget's disease of breast and vulva. For your easy remembrance of pictorial memory, I have kept both the slides. This is Paget's disease of bone. You are appreciating the mosaic pattern, cement lines, and cracking. Okay. But in Paget's disease of breast and vulva, you see all the cells, right? Here, everything, right? And this is stromal cells. Okay. Malignant cells. If you appreciate, they are dull, right? These cells are called as Paget cells. From here, all the malignant cells are coming into this region. They are called as Paget cells, and the disease is Paget's disease. So, Paget's disease is seen in bone, breast, and vulva. Paget's disease of breast and vulva will look similar, but Paget's disease of bone is entirely different. It will have mosaic pattern, cement lines, and cracking. This you have to remember. Till now, we have discussed the bone pathology. Coming to soft tissue tumors, The soft tissue tumors involves alveolar rhabdomyosarcoma, alveolar soft part sarcoma, angiomatous fibrous histiocytoma, clear cell sarcoma, congenital fibrosarcoma, dermatofibrosarcoma protuberans or DFSP, desmoplastic SRCT or desmoplastic small round cell tumor, extraskeletal Ewing sarcoma, extraskeletal myxoid chondrosarcoma, low-grade fibromyxoid sarcoma, myxoid liposarcoma, pericytoma with the T712, that is translocation 712, and synovial sarcoma. So anything among these, they are all soft tissue tumors. So soft tissue tumors can be rhabdomyosarcomas or histiocytomas or round cell tumors, dermatofibrosarcoma protuberans or desmoplastic, extraskeletal Ewing sarcoma or extraskeletal myxoid chondrosarcomas, myxoid liposarcomas. Okay. So in these, chromosomal translocations are different and fusion genes are different for these three, all these diseases, all these soft tissue tumors. We have no other go. Everyone has to by heart everything, all the translocations and fusion genes. My sincere suggestion is first you read the fusion genes, EW is there, no? You make a chart of EWs all together at one place, Fox or Pax at one place, and by heart it. This is one way of learning. The other way of learning is if you appreciate all these tumors are having, most of them are having 22. 1, 2, 3, 4, 5, 6. Okay. So you make a chart of all 22 chromosome involved in a order and by heart it. Or all 11 in a place by heart it. Or all 9 in a place by heart it. Our motto is to remember these things so that we can easily identify the histotype of this soft tissue tumors. Okay. Thank you for your patient listening. Please like, share and subscribe Dr. Ravichandra Official for more such interesting videos.